Central Health has developed a new healthcare equity plan with one primary goal: to develop an equitable system of care that is both comprehensive and accountable while optimizing our capabilities and resources. Welcome to Central Health Talks on KZI-FM 88.7. I'm Ted Burton with Central Health, and I'll be your host for the next 30 minutes. This morning, I'm joined by Mike Giesling, President and CEO of Central Health. Good morning, Mike.
Hello, good morning.
And Andrea Shaw, who's the Manager of Medical Management at Central Health. Hi, Andrea.
Good morning.
Thank you for being here to talk about this very important and at times somewhat complex topic. But Mike, before we dive in, let's talk about Central Health. What is Central Health and what is its mission?
Ted, Central Health is the public health care district for Travis County, and we were created by voters in 2004. And right now, we serve about 1 in 9 Travis County residents. And our mission is simple. It's provide access to health care for those who need it the most. And what that means is, if you are lower income or lesser resourced and you don't have health insurance, you have access to health care. And it's the full spectrum of health care: primary care, specialty care, preventative care, hospital care. And last year alone, we served over 147,000 unique patients through our programs and our partners that happen to be in over 200 locations around Travis County, and to the level of over 500,000, over 500,000 primary care visits.
And so these are people who are either low income, uninsured, underinsured, Travis County residents, correct?
Yes, that's correct.
Okay. Thank you, Mike. And Andrea, I want to learn a little bit more about your role at Central Health and how you interact with the patients that we serve.
So I'm the manager of the medical management department and also the lead case manager to work with patients that are most vulnerable and have complex medical needs. Our team consists of nurses, social workers, and community health workers. And we make sure that patients transition from their medical complexities to primary care providers, specialty care, and those patients that are facing transportation issues or can't access their medications, we make sure that they get connected to their resources.
So somebody might come to a clinic, they see a primary care doctor, and the doctor is going to refer them to a specialty care doctor, let's say an ophthalmologist. What would your role be there?
Our role would be the primary care provider would refer that patient to the medical management department at Central Health, and we would assign a case management team that consists of nurses, social worker, and a community health worker to connect that patient to the specialty ophthalmologist. We can provide transportation to them. We can make sure that they know when their appointments are, and we can also accompany them to their appointments so that they can understand better what the doctors are telling them.
I've heard this described as wraparound care. So you sort of wrap the patient and all of the care and the need and meet all the needs that they have.
Yeah, so we make sure that even though they have a referral for an ophthalmology appointment, we also assess the patients for other social needs that they may have and make sure that we are taking care of the patient as a whole.
Thank you. So today we're talking about health equity. And I want to start with you, Andrew. What does health equity mean to you? But most importantly, what does it mean to our patients?
Health equity means that our patients will have the same access as any other person in the world to access that health care, whether it be primary care or specialty care. They are on the same equal level and can access that care.
So whether you have the best possible private health insurance that's out there or you're on the medical access program, we want it to be the same, right?
Correct. We want it to be the same, and we have great providers within the medical access program that provide care to our patients as well.
So when you're working with patients, what are some of the most common barriers that you hear about or talk about for patients, whether it's seeing a primary care doctor, getting to a pharmacy? What do you hear in the clinics?
The number one issue that our patients are facing is transportation. So within our department, we're able to provide transportation to the patient's appointments. Whether it be to the pharmacy or to a medical appointment, we can provide them with transportation. We also see that patients are unable to afford their medications. So our community health workers make sure that they find resources to help them with that financial burden that they have for medication affordability. And then we also just make sure that we build a trusting relationship and meet them where they're at, go to home visits and see how they are living within their homes and if they need any other resources.
I think transportation is something that sometimes we take for granted. But if you have to see a doctor and then you get referred somewhere else, maybe your family has one vehicle, maybe you don't have a vehicle and you rely on the public transportation system, that can be a real barrier. And I just wonder, people sometimes just give up and don't even try.
That is correct, because they're not aware of the resources that are available in the community. Our community health workers are specialists in the resources that are provided within the community. There are community resources that provide transportation, and our community health workers are able to connect them to those different resources.
We're going to come back to this topic in a minute, but Mike, I want to bring you back into the conversation and talk about what Central Health has recently done regarding the adoption of a health equity plan. What is a health equity plan?
Well, for Central Health, the health equity plan is looking at the data and listening to our patients and then devising a plan to overcome disease disparities that have a disproportionate impact on the communities that we serve. And recently, that is in February of this year, the Central Health Board of Managers adopted a health equity plan that was based on two fundamental pillars. One is a community health needs assessment for those that are living below 200% of federal poverty level, and really understanding people in place and disease burdens and the disparities and what causes those underlying health conditions. And second, the voices of the community. And you were involved in this, as well as a number of Central Health staff and partners, and reaching out and having meetings and focus groups with patients and advocates in multiple languages and understanding what their perspectives were. And so you put those two things together, and that built the health equity plan that we're working on today.
So these aren't new problems, right? They've been around for a long time. And in fact, I think we know, and we've talked about, that systemic racism in the health care field and in our community is real. And it impacts people's lives, and it frankly has shortened people's lives. How does the healthcare equity plan address for this, account for this, and frankly begin to solve for this?
Well, first, it acknowledges, and we own up to, as a community, that there is systemic racism. Not that there has been, that there is. And then it's a firm and strong and unwavering commitment to undo that systemic racism. And this plan lays a roadmap that we can work with the community and advocates and patients in putting together high-functioning systems of care that overcome these disease burdens, these disease burdens that were caused by systemic racism.
Andrea, as a person of color, I want to ask you just personally, can you speak to this, and maybe either perhaps personally or just what have you seen from our patients, and how does this long history of racism in our healthcare system impact people's day-to-day health?
You know, it does impact the patient's day-to-day health. And just thinking back on my experience here at Central Health, building a relationship with the patient, a trusting relationship with the patient, and empowering them to stand up for their health care and make sure that they get the care that they need by educating them and making sure that they have access and understanding what that access is to health care.
And not just educating them, but also educating the people that interact with them. The person at the front desk, the person who, the medical or assistant in the clinic, the doctor, the nurses.
Yes, educating them, especially on the cultural differences, and making sure that they understand where the patient is coming from and their beliefs is important. If they understand their beliefs, then that builds the trusting relationship as well, and that kind of releases some of that disparity also.
So, Mike, I want to talk about the Healthcare Equity Plan, which is available on our website, centralhealth.net. but we need to also acknowledge it is complex. Building a better healthcare system is not going to happen overnight. It wasn't broken overnight, so to speak. But in this healthcare equity plan, we began with what we call, and you mentioned it earlier, the voice of the community. I just want to know more about what is that part of this project and why was it so important to hear from the people that we serve, from organizations that are caring for and serving the people that we serve. Why was that voice so vital to this project?
Yes, and over the years, and it seems like that as the months go by, we get better and better at our data and our analytics and understanding who our patients are, where they are, what their health conditions are, what is challenging their health conditions, and is a barrier to them living the healthiest life possible. And while all of that data provides a lot of insight, there is nothing that can replace sitting down and having a conversation with somebody that either is currently in the medical access program, which is how we fund care for our patients, or maybe they know somebody or they were in the MAP program, which is, again, the medical access program themselves, and capturing their perspectives, their lived experience in the healthcare system and what it should be. And while, again, the data can tell you a lot, they can't give you that human perspective and that lived experience. That comes from firsthand conversations.
And so during the voice of the community phase, you gathered input from more than 300 people, one-on-ones, surveys, community conversations. And then what happened to that information?
Right. Well, along with the community health needs assessment that we mentioned earlier, which looked at a bunch of different data and looked at geography and location and communities of interest and neighborhoods, demographic information, we took this voices of the community, which again are people's perspectives on the healthcare system, and then by putting those two together, it identified what the gaps are in the healthcare system. Some of this we knew, but we really wanted to know at a more granular level just exactly what were those gaps and where are they. And so now we have the what. And the voices of the community help really put a lot of information around what that is in terms of the gaps that we need to fill in our healthcare system, which leads us to the next phase.
You know, it's interesting, and we're going to get to the next phase in just 1 minute after the break, but many of the things that we heard in the voice of the community, Andrea, I know you weren't necessarily part of that process, but everything that you've talked about and everything that you've lived through your profession are things that we heard in the voice of the community, and I mean specifically the barriers to healthcare. I mean, so it's like we've had the data, we have the experience that you've shared with us. What do you think we should do with that now?
I think we should put it into action. Listen to the voices of the community, use the experiences that we have, and develop more robust plan to make sure that we take care of the patients that we see in our system.
So we're going to talk about that in just a minute. But first, support for Central Health Talks is provided by Central Health, the Travis County Hospital District. Central Health creates access to health care by funding the Medical Access Program, or MAP. MAP enrolls low-income, uninsured, and underinsured Travis County residents, connecting them to a broad network of providers and other healthcare services. If you or someone you know needs healthcare, call 512-978-8130. That number again is 512-978-8130, or visit applyformap.net. That's APPLY, the number 4, map.net. Welcome back to Central Health Talks on KAZI FM 88.7. I'm Ted Burton with Central Health, and I'm joined today by Mike Giesland, Central Health President and CEO, and Andrea Shaw, a Central Health Case Management Leader. Thank you for being here again this morning. We've been talking about the new healthcare equity plan by Central Health, and I want to go back to the plan itself that the Board of Managers for Central Health adopted earlier this year and talk about the 4 main priorities of this plan. It's about patient access, the capacity to care for patients, care coordination, and Andrea, this is what you do day in, day out, member enrollment and engagement, how we get folks enrolled in the Medical Access Program or MAP and keep them enrolled and make sure they're fully using all the services that are at their disposal. And then what's called a systems of care infrastructure. Sounds a little complicated, but it's really not. Making sure that we have a system in Travis County to care for people who need our help the most. Mike, I want to circle back to something that Central Health did last year, which was the first ever healthcare safety net needs assessment. It's a mouthful. What does that actually mean? What was this community health needs assessment, and how is it going to guide this healthcare equity plan?
Yes. So this needs assessment looked at people and where they are and where they live and who they are. And this is important because if you're going to provide health care to people, you don't want to just set up a system and think, well, it's going to work for everybody. You really need to meet the patient where they are. And what this needs assessment found was that there's widespread poverty, and we know this in almost all parts of Travis County. It's more densely concentrated in certain areas, though. Now, one of the surprises was the concentration of poverty up and down the I-35 corridor. And if you think of if you think of I-35 as just a line on a map, it doesn't make much sense. But when you expand on either side of I-35, particularly on the eastern side, there's a corridor that's relatively narrow that runs through the county, where you have 74% of the residents with incomes below 200% of the federal poverty level living. So that's 74% of Travis County residents who are below 200% of the federal poverty level live up and down the I-35 corridor. And while the diaspora and the suburbanization of poverty is very real and unfortunately continues in Travis County, in which we need to work to overcome, what we're not seeing is a complete deurbanization of poverty. And we anticipate that this high poverty corridor will continue for many years to come.
And I think that's a little bit of a shift. We know, at least in the thinking about where the greatest need is, we know that people are leaving the city, moving out in the county because of the high cost of living, rent, everything that we talk about every day. And Andrea, I'm sure what you hear from our patients, it's just more expensive. But I think there may be a little bit of a misnomer that because people are moving out, and we know that, and we're doing things to provide care in the outskirts, in Travis County, there's still a lot of folks in need living along that 35 corridor, the Runberg area, southeast Austin, Dove Springs. Is this kind of what you see, Andrea, in your work?
Primarily, our patient population is South Austin and North Runberg area, and we do see those low-income patients that cannot afford rent or cannot afford their medications, cannot afford to put food on their tables. So we're working with the most complex patients and trying to connect them with various resources throughout the community, as well as keep their medical treatment plan in the forefront as well.
Yep. You probably don't need a needs analysis to figure out where the need is because you see it every day. But I think I should ask you, regardless of where people live in the community, are the needs similar?
They're all similar. We're seeing heart failure, we're seeing diabetes, we're seeing chronic kidney disease, and all of those are coming into one patient. They have complex medical conditions that don't allow them to go to work every day. So there's that financial burden as well. So we see patients all across the spectrum.
Mike, you mentioned, and we've mentioned it several times, the federal poverty level, and I wanted to mention that Central Health serves residents who are up to 200% of the federal poverty level. What that means is approximately for one person, it's an annual income of $27,000. And for a family of four, it's $55,000. So those are the real numbers behind the people that Central Health is serving. Part of the healthcare equity plan was what's called a capabilities and gap assessment. Mike, what is a capabilities and gap assessment?
Well, think of the healthcare system of what people deserve and need to live the healthiest life possible if we're talking about healthcare equity. And so it's It's thinking about primary care, specialty care, but also preventative care. I mean, if people are healthy, let's keep them healthy. Let's not just have sick care. It's care management that Andrea's talking about. It's linking people to resources. It's also transitions of care. If you're discharged from the hospital, having a plan in place to safely and comfortably discharge you from the hospital, and to be able to have the right follow-up, and also providing street medicine for those that are experiencing homelessness. It's the full spectrum of care. Now, when we think about the people that we serve today and who we need to serve tomorrow and next year and 5 and 10 years down the road, there are going to be gaps in that healthcare system. And so by identifying those gaps, again, on all those areas of care that I just named, then we work to fill those gaps and build them up so that that high-functioning system of care is there for everybody that needs it.
You know, those numbers are really important because last year Central Health did serve approximately 147,000 Travis County residents, and we know now that there's an additional 90,000 that would qualify or could access our care. And so that's a challenge as well, is not only identifying who they are, where they live, but then how do we connect and how do we engage?
Right, and I think it's important too, as we talk about, I mentioned integrated mental behavioral health is having affirming care systems, but also making it easy to access health care and not have to go to all these different places. But by establishing a medical home and these trusted relationships that Andrea speaks to and practices every day, word gets out. That's one way. That's one way we can connect, is through our patients connecting with the community. Another way that you're familiar with is we're present in the community through community healthcare workers, through our partners, and connecting with people in person and helping them get enrolled into the medical access program. We also have a call center where you don't need a computer to enroll in the medical access program. You can get on the phone or have somebody help you get to a telephone and make a phone call, and we can work with you over the telephone to make that happen. We can also work with you again in person at some of our resource centers that we have that are affiliated with our clinical partners. So there's a number of ways that we can do this, including online enrollment, but I'll pause there.
Yeah, and a reminder, that phone number, if you or someone you know needs access to healthcare services, the number for our medical access program, or MAP, is 512-978-8130, 512-978-8130. Andrea, part of the capabilities and gap assessment that we've talked about that was part of the healthcare equity plan looked at social conditions. And what we mean by that is, or what we know is, racial and ethnic minority populations right here in Travis County are more likely to be vulnerable, socially vulnerable, simply because of where they live, how they live, substandard housing, lack of access to health care, lack of access to healthy foods, and ways to exercise. And I'm wondering, is this something that you see when you work with patients as well, the folks that come into our clinics?
Correct. And Ted, with our department, we work in the transitions of patients wherever they're at. The homeless patients that are seen in the emergency rooms, we help connect them with medications, transportation. We'll go down to the Arch, me and my team, and meet with the patient where they're at. So yes, we do see those, and we connect them where they're at and keep moving with them.
And I think that's something maybe we don't always consider, but if you are unhoused, if you have nowhere to sleep at night, getting medical care can be extremely complicated. You don't have an address to write down. There's no way for people to reach you. Perhaps you don't have a phone. Are these the things that you see?
Absolutely. And our wonderful social workers connect these patients with Sunrise Church, or make sure that they're getting a coordinated assessment to assess them for their homelessness and possibly get housed in some of the community resources. Our team also has access to medical respite if we have patients that need a little bit of respite.
What do you mean by that? We use that term a lot, but what does that mean to somebody?
Where they can go and rest and take care of their medical needs, and make sure that their medical needs are addressed and they have a place to live for a short period of time, and then we help discharge them to somewhere safe.
So it's not a hospital, but it's somewhere just to rest, recover, get some attention?
Yes, it's just respite for them to recover from their medical condition, their current medical condition. We also have a contract with a residential rooming boarding facility as well, where we can house some patients that have that longer complexity of medical needs and make sure that they have housing and 3 meals a day. There's a subset of patients that we can approve for that service, but we do have that available for our patients as well.
Mike, I want to talk about this healthcare equity plan. One of the really important things that it did was identifying the lack of providers that we have now and how many we're going to need in the future. Could you talk a little bit about that piece? Because it's really important. We talk about doctor shortages, but that impacts people's lives.
Yes. So part of the health equity plan and the needs assessment that we talked about earlier, it shows us here's the number of providers, both primary care providers and specialty care providers, that we will need to either contract with or hire or working through our partnerships, bring into the safety net system.
All of us can relate to wait times, calling for a doctor and being referred to a specialist and them saying, well, our next appointment is 6 months from now. Not only is it, from a health perspective, difficult or impossible, emotionally, it's really challenging and can be deflating.
It is, and it has an impact on an individual, again, not just from a physical health, but from a mental health standpoint as well. And Ted, it's important for everybody to understand what we're talking about today, yes, is a roadmap that's going to guide the work that we do into the future. But right now, today, and Andrea's covered a number of partnerships that we have. We are providing this care today, and so for instance, in the space of specialty care, right now we are looking at the Rosewood Zaragoza Clinic as a place to start a specialty care practice, and we are working right now with specialty care teams and putting them together, and we hope to bring that online next year. We have substance use disorder partners that we are contracting with to provide more substance use disorder support out in the community. So this is work that is happening today.
We've talked about this kind of high-level healthcare equity plan, but Andrew, when the rubber hits the road, so to speak, what does it really mean to our patients, and what is our greatest challenge, and what do you look forward to the most?
I look forward to working with the patient as a human, as an individual, getting to know them, their life, what's important in their life, and making sure that we keep that at the forefront as well as their medical treatment plan as well.
What will you look for to know that we're doing something right?
Just the patients continuing to interact with our team is success. A lot of times patients can discard our calls and not participate, but just that continuing participation is success.
I want to thank you both for joining us this morning on Central Health Talks on KAZI FM 88.7. We can continue the conversation on Twitter at Central Health TX or like us on Facebook at Central Health TX. You can also send us a direct message and we will get back to you, we promise. I'm your host, Ted Burton. Thank you, Mike. Thank you, Andrea. Thank you. If you or someone you know needs access to health care, please call 512-978-8130 or visit our website, centralhealth.net. Thank you.